Second presenter, we have Dr. Pranita Sahay. She'll be taking up the topic of corneal topography. Right? She's the assistant professor in Maulana Azad Medical College, and she'll be dealing with corneal topography. She's a MD, senior resident from RPC AIMS, Delhi. So, Pranita, please.
Thank you. Thank you for that kind introduction. So, good afternoon, everybody. I'm Dr. Pranita Sahay, and I'll be discussing about corneal topography. So, basically, first, what we need to understand is what is topography and tomography. So, while topography assesses the shape of the corneal surface, tomography gives you a three-dimensional assessment of the cornea. That is, it gives you a true estimate of your posterior corneal contour. So, the Placido-based topography systems, that is your older version of OpScan and video or VKG, were your topography system, while the Pentacam, Galilean series based on the Schimflug imaging are your corneal tomography system. Obviously, the tomography is a more advanced system, gives you a better assessment of the cornea, and hence that is what is most widely used these days, and that is what I'll discuss in the presentation today. So basically, the idea of the tomography came with the Schimflug imaging, which was first conceptualized by the Theodor Schimflug himself. The Pentacam has two cameras. One has a central camera which gives you a detection of the pupil size as well as the fixation, the central fixation of the eye. The second camera has a rotating Schimflug camera which captures 360-degree image of the eye. But the camera rotates only 0 to 180 degree so that the nasal shadows do not cast a problem in image capture. Now the light source that is there, you all need to know that the Pentacam or topography images are captured in dark room. Hence, so that the image of the eye is captured, there are UV-free blue light inbuilt in the Pentacam system that helps in capturing the eye images. It utilizes a ray tracing algorithm to construct and calculate the anterior segment image, and even minute movement of the eye can be detected by these machines, and it will reflect onto your quality of scan when you're looking at the images. So as I told you, it captures images in 0 to 180 degrees. Slit images are captured. Almost 50 images are captured in just a fraction of 2 seconds. There are 2760 elevation points in each image. A total of 1,38,000 true elevation points are estimated. That is, even minute changes in your corneas will depict in your interpretation images that you will see. Now, as the name reflects in Pentacam, it reflects that it assesses 5 parameters. The 5 parameters are pachymetry, corneal topography, anterior and posterior corneal curvature, astigmatism determination, and Schimflug photography of the lens. So, when you start capturing an image of Pentacam, this is the first thing that you see on the screen. On the right bottom that you see here is the guide for your joystick. How do you want to move your joystick so that a central fixation of the eye is obtained. So it gives you a guide whether you want to rotate the joystick up, down, forward, backward, so that a proper centered image of the eye is captured. It automatically detects whether a right or a left eye is being detected, is being captured, and this is the Schimflug images that is currently being assessed. Now, once you capture the image, which will be captured in just 2 seconds, this is the first image which will reflect on your screen. So, on the top, what you can see is the camera slit position image. As we said that there are 180 degree, 0 to 180 degrees captured, different angles are being captured. So, if you want to look at any specific particular angle, you can change these segments and look at that particular angle only. On the right top, you will have the patient data and you will have the keratometry values. And this map is variable. You can choose which map you want to see, whether a pachymetry map or a curvature map or an elevation map. And on the bottom left, you get a 3-dimensional model of the anterior chamber. Next, we'll move on to the specific characteristics that you want to look at the map. So before you interpret any map, you first want to know whether you should read this map or not, whether the quality is good or not. That depends upon this QS value, which is the quality specification scan. That needs to be okay. So then only you proceed to read the scan. If this area is in yellow or red, that means the scan is not appropriately captured. There may be blinking of the eye, or lid opening may not be adequate, and hence you want to repeat the scan before you go on interpreting it. Next is the Q value. The Q value is just below the QS. It gives you an idea of the shape of the cornea. Normally the cornea is prolate in shape, that is centrally steep, peripherally flat. In such cases, normal value is 0 to -1. If your value is reaching up to -1, that means it is hyperprolate. Usually in keratoconic eyes is that what you see. And in patients who have undergone myopic LASIK or myopic photoablation, the shape usually becomes oblate, wherein central cornea becomes flat, values will become positive. So this Q value can give you an idea of the shape of the cornea. Then there is a concept of reference body or a reference sphere. So these machines have certain reference spheres, which can be a reference sphere or a reference toric sphere, with which the patient's curvature is matched, and a difference map is given which reflects as your elevation map, which will tell you whether the patient's curvature is over and above the reference sphere or below the reference sphere, reflecting in your elevation maps. Every map is color coded in this. You see beautiful colors from blue, green, red, yellow, all colors. But what do these colors mean? You need to understand. So in elevation maps, blue means flat, red means steep, that is elevated over and above your best fit sphere. So over and above a reference sphere, if the patient's cornea is steep or elevated, that will reflect as plus or red. And if it is flat, it will be below your reference sphere, it will be blue or minus values. So this is a representation of an elevation map. In normal corneas, as I told you, it is prolate, so central steep. What you can see, this yellow line is the patient's corneal contour. It is going above your reference sphere, which will reflect as yellow or red in your color map. In the mid periphery, it is dipping down your reference sphere, hence the cooler colors blue. In the periphery, again, what you see is it is going above your reference sphere, hence the hotter colors yellow and red. So that is how your color coding of the maps is done. Moving on to the pachymetry map. Here, cooler colors depict thicker corneas and hotter colors are thinner corneas. So in this map, what you can see is paracentral area is red, that is thin, and this thinning is decentered. So that is what you most commonly see in keratoconus. You see thinning and decentered thinning that will be reflecting on your color coded maps. Now this is the holistic 4-quad map that you see most commonly, that you read for any patient. So how do you go about reading it? As I said, first you look at the quality of scan, that looks okay. The Q value here is minus 0.99, red flag, looks like patient may have keratoconus. You look at the curvature map on the left top, you are seeing hot colors, that means the cornea is steep. You look at the numeric display of keratometry, the keratometry is going up to 51, that means it is over and above the 47 cutoff that we consider for normal corneas. That means the cornea is steep. You go on to looking at the pachymetry, you again see red colors, that means the cornea is thin, and the thinning is corresponding to your steep cornea, that is thinning and ectasia or steepening are corresponding to each other. Most commonly that is what you see in keratoconus. Again you look at the posterior elevation, again the site of the posterior elevation is matching with your steepening and thinning, that is pathognomic for keratoconus. The next map that you read after the 4-quad map is the Bellin-Ambrosio enhanced ectasia display, wherein came the concept of the enhanced best fit sphere. So while the best fit sphere, it takes the enhanced best fit sphere excludes the central 3 mm area of the patient's keratometry value, the steepest keratometric area, and because of that you get a flatter best fit sphere, and even form frustrated keratoconus or subtle elevations will be depicted there. Two other parameters that are seen in the Bellin-Ambrosio enhanced ectasia display is the corneal thickness spatial profile, wherein the thickness from the center to periphery is measured in this pattern, and the percentage thickness increase, that is the percentage by which the thickness is varying from center to periphery, is measured. The two dashed lines represent two standard deviation, which is the normal range. Anything going above and below it is abnormal and should be looked into. So this is the holistic Bellin-Ambrosio enhanced ectasia display, wherein you see the posterior elevation, although showing red, this red colors are getting enhanced into the enhanced ectasia display and is reflecting on your difference map. I'll just take one more minute. So these are some parameters that you need to remember whenever you are assessing any patient for topography. There are subtle findings that these are basically theoretical, but you need to remember these values so that you can identify patients of keratoconus and form frustrated keratoconus. Most important is the posterior elevation, which should be more than 17. Anterior elevation, if more than 12, is abnormal. So this is just 3 cases I'll show. In this case, what you see is your You have a with the rule corneal astigmatism. Cornea is looking steep, but when you look at the thickness map, the thickness is normal, posterior elevation is normal. So this is just a normal steep cornea with the rule astigmatism. Again, now this is a patient with a steep cornea. You are yellow in the center, but there is some thinning associated with decentration that you see in this map, and that is indicative that the topography is not absolutely normal. And you would like to repeat this topography maybe after 6 months if the patient is coming up for a refractive surgery. D value again is important, which if is above 2 means that is a red flag sign and you need to repeat the topography after some time. Just the last map. This is a map of a patient with pellucid marginal degeneration, where you see a classic crab claw appearance, that is kissing dove appearance. The inferior cornea is steep and the thinning is just above, is not exactly corresponding to your area of steepening, unlike keratoconus where the two areas correspond absolute to each other. So with that, I'll just conclude because it's an extensive topic. So
What is the take-home message, especially for people who are not too much used to corneal topography readings and all?
Yes.
So what is the take-home message? How
the
can they?
take-home message is at least you should be able to understand the 4-quad map, so that once a patient comes with you a map and you see hot colors, red colors, you should be able to identify, yes, the topography is not normal. And at least keratoconus is something that you should be able to pick up, wherein you should see whether the steepening, thinning and elevation, all if are corresponding to each other. That means you're looking at it ectatic cornea. So definitely screening before refractive surgery or planning for any surgery.
The pachymetry map is also important. That has to be correlated basically.
Yes, correlating the 3 important maps,
So
the
thank you-
pachymetry,
thank-
elevation and curvature.